This is in continuation of last session. Last week, it was disinfection, sterilization, asepsis routines. Today, we have Ansa Maheen, our fellowship student, neonatal nursing fellowship student, and she'll be presenting. And we'll start, no, madam? Yeah, over to Ansa.
Yes, we should start.
Good afternoon, ma'am. I am Ansa Mahi, NNF Nursing Fellowship student at King's Health. Today I'm presenting second part of disinfection and aseptic routines. Disinfection and sterilization was extensively covered during last section. Today I will be discussing aseptic routines in NICU. I will refer it from CDC, SHIA guidelines, Cloherty and Stark's Manual of Neonatal Care. Sterile womb to busy NICU. We all know that babies inside mother's uterus is mostly a sterile environment. When they get admitted to a busy NICU, they are at risk of infection. Highly vulnerable, all defenses breached. Neonates are the most vulnerable population. All the defenses breached. Studies shows that they are approximately 7 times more prone for infectious compared to adults. Burdens of HIA. The burdens of HIA, which includes morbidities including neurodevelopmental concerns, increased antibiotic use, prolonged hospital stay, increased healthcare cost, and mortality. What are the common healthcare associated infections?
Are the slides moving? Sorry. Are the slides moving for everyone? I'm not able to...
No. Still in the first slide. Ma'am, can you make it full screen?
1 minute. It is in slide studio. It's in presenter mode actually. And
for just click on the enable editing option.
I'll just stop sharing and restart it again.
Okay.
Which one is seen now, ma'am? Is it common HAI in NICU?
Ma'am, can you make it full screen? Because it is on the presenter mode. If you make it full screen, it will be easier for the other doctors to understand.
That's right. Actually, it should come only at our end as.
Can you do that end show? Click
I
on
will
this.
do. Is it okay now?
Yes, perfect.
Can she just continue from where she left off?
Yes. If you're comfortable with that, then you can continue.
Common healthcare associated in NICU are CLABSI, central line associated bloodstream infection, ventilator associated infections, VAP, skin and soft tissue infections, and surgical site infections. Strategies for the prevention of HIA are education and privileging of staff, proper hand hygiene, early enteral nutrition, breast milk, care of central lines, ventilator care, dedicated equipments, skin care, cohorting, antibiotic stewardship, and cocoon vaccination. We will discuss one by one. First is the education of staff. Education and privileging of staff. This is very important for prevention of infection in NICU. This includes regular staff training on standard operative procedures, supervising procedures, hands-on training, training through videos. All these can be helped to train healthcare staff. Vigilant monitoring and audit is very important. Root cause analysis of non-compliance. We should analysis why and not whom. Pointing fingers to persons should be avoided as much as possible. Feedback. Each care provider must comply with asepsis routines. Next is the proper hand hygiene. This has been discussed in detail during the previous section. All types and movements are as per WHO guidelines should be followed. Clean touch zone, hand hygiene after contact with the equipments and other objects after removal of sterile gloves. Alcohol-based hand rubs are effective, convenient, and improve compliance except when hands are soiled. Next is the prevention of clumsy. The risk factors of clumsy, which includes skin colonization, urgent line placement with limited use of sterile precautions, contamination of catheters, long dwelling time, poor asepsis techniques. The pathogenesis, the main route of spread of infections are through catheter tract contamination. This can be prevented by proper skin asepsis before line insertion should be practiced. Next is through hub contamination. This can be prevented by proper hub care. The tip of the hub should be cleaned vigorously, cleaned with the alcohol swab for 50 seconds before and after administration of medicines. Avoid frequent disconnection and entry into lines, and proper hygiene be practiced while doing hub care. Infusate contamination. Avoid using infusate beyond 24 hours. All IV preparation, example, IV fluids, PN should be changed after 24 hours. Hematogenous spread is also a reason for clumsy. Next is ANTT, aseptic non-touch technique.
ఇది వింటావా నువ్వా తర్వాత ఫీల్ అవుదావు కానీ
All the procedures should be done, followed. ANTT should be followed before any procedure. Through proper hand washing, hands become sterile. Proper gloving should be done. For doing any procedure, protecting key part and key site. For doing any procedure, there should be a key part and a key site. For example, cannulation like procedure. The key part is the tip of the cannula inserted of the baby's skin, and key site is the skin, the area we were pricking. Both the sides should be sterile and never allow them to become unsterile. This procedure should be done in a sterile field. Non-touch technique, only sterile equipments should be come in contact with that sterile field. Maintain aseptic field. Clumsy prevention, optimizing catheter use, weigh the risk and benefit of placing the line, evaluate daily whether central line is needed. UAC should be kept for maximum 5 to 7 days. UVC should be removed as early as possible, which should consider the removal before 7 days. Strict asepsis, maximal barrier precautions, PPE, big sterile drape, sterile articles, strict skin asepsis, 2% chlorhexidine alcohol should be safe in babies greater than 1,500 grams. We use 0.5% chlorhexidine alcohol less than 1,000 grams. Minimize use of connection or port. Each port must be considered as an independent opportunity for infection. Connecting port should be kept away from areas contaminated by diapers. Central line care. Use sterile, transparent, semi-permeable dressing to cover the site. Replace the dressing when it is soiled or loose. Use sterile gloves during dressing change. Hub care. Vigorously scrub the connectors for 50 seconds before and after entry with the alcohol swab after performing hand hygiene in a sterile field. Dedicated line for parenteral nutrition. Replace IV fluid and PN for after 24 hours. Use needless connectors. Minimize number of times lines are assessed. CLABSI prevention. Strict asepsis routines should be used. Use of laminar hood for drug and IV preparation. Use sterile articles. Use sterile field for procedures. This can be prevented CLABSI. Next is the VAP prevention bundle. Privileged staff, strict asepsis, separate kit for each basenet. Only one-time use of ambu and laryngoscope should be used. Head end up, ET or head end up or endotracheal in horizontal position. Correct ET fixation. Avoid head position changes, that is flexion and extension of head. This can decrease ventilator associated pneumonia. VAP prevention. Knowledge of caregiver. Strict hand hygiene. Avoid the use of invasive ventilation. Daily assessment of readiness to extubate. Avoiding accidental extubations and repeated intubations. Regular training on aseptic prevention during procedure like intubation, ET suction, surfactant administration, etc. is very important. Strict hand hygiene should be practiced. Avoiding the use of invasive ventilation if possible. Daily assessment of readiness to extubate. Avoiding accidental extubation and repeated intubation. Repeated intubation is known to increase the risk of VAP. Changing the ventilator circuit. The other practices should be followed for VAP prevention are changing the ventilator circuit when visibly contaminated, draining condensation from the ventilator circuit when visible, performing mouth care routinely, give oral suction before adjusting endotracheal tube, suction endotracheal tube only when secretions are seen or tube block is suspected. In sterile procedure, closed suction has been shown to decrease the risk of VAP. Next is humidification. Humidifier temperature should be kept at 37 degrees centigrade. A good humidifier with no significant condensate in the circuit is very important to prevent VAP. Care of ventilator circuit, sterile PEEP valve for each baby. Change ventilator tube when soiled. Condensate should be minimal or discarded as per infection control protocol. Next is the skin care. Skin care is the most important immune organ. Premature babies have immature skin and are highly prone for skin breaks and infections. Regular assessment for any skin breaks, minimize skin breaks, minimize adhesives or careful removal of these adhesives. Try not to change or remove adhesives within 24 hours of application. Use topical drugs appropriately. Wipe off excess antiseptics. Change positions of prop each shift. Topical emollients should be used for improved skin integrity and barrier function and thereby prevent infections in preterm. General measures to decrease HAI. Early breast milk in NICU. Breast milk with its high immune properties has an important role in prevent infection. Breast milk availability can be increased by antenatal counseling, early use of breast pump, allowing mothers early in NICU. Early advancement of enteral feeds will decrease the need for parenteral nutrition and the risk of infection. Kangaroo mother care, KMC is associated with the low infection rates. Early initiation and longer duration are associated with the benefits decreased late onset of neonatal septicemia. Probiotics. Preterm babies have abnormal intestinal colonization, often with pathogenic bacteria, and have low number of probiotic bacteria. Several studies have reported that probiotics, which can reduce the risk of loss in low birth weight babies. Still, uncertainties exist regarding appropriate dosing, strain selection, and the safety of these products. Disinfection and sterilization routines, equipment cleaning and environment cleaning is very important. Specific disinfectant for each procedure discussed in last section on 3rd July. Antibiotic stewardship, limiting the use, avoid empiric antibiotic treatment, always send blood culture before starting the antibiotics, change to narrow spectrum based on sensitivity. Good infection control practices plays a significant role in restricting antibiotic use. Cohorting during outbreaks, assign dedicated healthcare personnel to care for one baby and not move between the babies. That is, in restricted personnel who give care to infected or exposed babies from giving care to uninfected or unexposed babies. Cocoon vaccination. Consider vaccination of caretakers to protect the preterms. Viral infections are also common causes of healthcare associated infections or late onset infections. Quality improvement, regular training, updating SOPs, conducting root cause analysis, feedback is very important to improve compliance to aseptic routines. Teamwork or constant vigilance, even with advanced technologies, life of a tiny baby can be jeopardized by smallest of facts. Example, neglecting hand hygiene. Thank you.
Madam Ansa has finished her presentation. Over to you, madams. Dr. Pratima, Dr. Geetanjali.
Yeah, Gitanjali, would you like to add on first? Then I'll comment maybe.
Okay, congratulations, Anza, for extensively covering the very important topics. I have to just ask and add also, I just wanted to know how do you do the skin asepsis, aseptics in infants and neonates in your unit before insertion of any of the lines, the central lines? Anza, am I audible?
Yes, ma'am.
How the skin is prepared before insertion of the central line or the lines, IV lines in your setup?
Chlorhexidine.
You use chlorhexidine. Okay.
Chlorhexidine alcohol combination is what we use in our unit, madam.
Okay.
That 2% chlorhexidine, actually, we are not using it in our unit. Aqueous chlorhexidine, we use chlorhexidine alcohol.
Combination. It's a combination which should be used actually for cleaning the skin. And how long it is being applied on the skin of the neonate?
2 seconds. how long you will apply.
So do you clean it after application? Do you clean it with any of the do you clean it with normal saline, sterile normal saline swab also
No,
after application?
no.
I just wanted to clarify also from Dr. Pratima, isn't it recommended to clean after the disinfection of the skin, to clean, wipe off the skin with the normal saline, sterile normal saline soap swab?
Ma'am, what we do is we use a chlorhexidine 0.5% weight by volume with 70% alcohol. And then we allow it to dry completely. And then we go ahead with the procedure after strict asepsis of 2 or 3 times of swabbing well in a sterile field. But we do not wipe that area again with sterile saline. The parts which have gotten excessively exposed, that is maybe if it has dripped behind the baby during a UVC insertion, or if it has gone behind the arm, if it's a PICC line insertion, that part we do wipe off with saline, ma'am, but not the area of insertion. We just wait for it to dry and then go ahead with the procedure.
Okay.
Yeah,
Yeah,
you
I
don't
think, Geeta,
you don't
yes,
clean
ma'am.
it with the again with the slime. And for cannulation, simple cannulation, it's 0.5% chlorhexidine, and or
70%.
betadine is actually not recommended. So 3 times with the spirit swab.
Three
And for
swab
the
technique.
central line, 0.5% chlorhexidine or up to 2%, but not in ELBW. So
That's
there
right.
aren't any guidelines for using it in ELBW because of the issues. Even in VLBW, there has been issues which has been found in larger studies also, that there is skin induration which is left behind. So weighing the benefits and risk. So risk is considered to be slightly more in terms of induration. That is why it is not being routinely used in these babies. But definitely you leave it for few seconds, and the contact time is 30 seconds, because alcohol gets evaporated in 30 seconds.
Right. We
And
just
you
And
don't
ma'am, I
wipe
also
it with the
read that
saline.
we should clean the skin, or in case if it's a very low birth weight baby, or it's a very preterm baby, the skin of the baby after the contact time, it should be cleaned with sterile saline swabs, and then the line should be inserted.
No, there is no such guideline that you clean it with saline by WHO or CDC. The guideline is only cleaning it with the alcohol rub, chlorhexidine. Rather, it is recommended 2%, not 0.5% volume by weight. But for when it comes to the neonates, especially ELBW, and in some of the studies, even up to VLBW that has been taken, it causes erythema and redness. That is why it's not recommended that you use up to 2%. As of now, there is no such guideline using it with 2%. But
Yes,
there's
ma'am.
no such CDC guideline or WHO guideline to clean it with the normal saline.
But
So
your
what we
point
can
is,
do, Gitanjali, what we used to do, I think, is squeeze the swab very tightly so that there is no
Yes.
dripping of the disinfectant. No, the concern for prolonged contact remains when there is dripping of the disinfection, too much of disinfectant taken on the swab, and it is dripping to the back of the baby. So if that
And for
can be
the central
squeezed
lines, even
properly.
betadine still continues. It is not said that you don't discard betadine usage.
Yes, yes.
There isn't any, because every belt is not G6. Only apprehension amongst the clinician is that G6 period deficiency get precipitated by the use of betadine. But every belt is not G6 period deficient. It's only the northern India belt. In southern India, western India, especially South India and East India, you don't have any G6 period deficiency. So the larger study says that there is no such contraindication for central lines. At least for the central lines, you have to go by the same procedure of what is recommended. Even the betadine part is recommended, but there isn't any use of saline in this. And as Pratima said, you squeeze it so that it doesn't go behind the baby. Usually we are putting umbilical lines or even your PICC lines. Then if it is not properly squeezed, it's like the one when they do painting in adults. In adults, it is called as painting, rather painting of the area. This is what they use, where we don't use the word painting of the site. So here we are cleaning, they are doing the painting. That is why in adults it keeps on dripping even from the sides.
Okay, ma'am. It's not given in the guidelines also, but few of the review papers have recommended that we should clean the minimum area which is required, and the surrounding areas at least should be cleaned with the sterile normal saline swab, so that there is minimum absorption of the cleaning agent.
See, when we
hello.
talk of teaching, especially in a group or in a masses, we always recommend what is the standard guidelines. The guidelines are not saying it.
Can I say something?
Yes, yes,
We
please.
We have expert Dr. Pratima. So let's listen from her. Dr. Pratima, what you were doing in AIMS and now what you are doing in your hospital. Kindly tell about your experience and advise us.
Yeah, we were not cleaning with normal saline, but yes, we did take care that the prolonged contact should not be there. And the type of disinfectant which we used, as ma'am said, was spirit betadine and spirit in VLBW babies. Recently, the unit has shifted to chlorhexidine, and at Harding, we are using 3 spirit swab technique for extremely low birth weight. Otherwise, the 3 swab technique we are using normally, and taking care that there is no, prolonged contact by avoiding excessive disinfectant. So that is what we are following. We are not cleaning yet with normal saline after betadine or spirit or chlorhexidine. We are using spirit only, 70% alcohol. We are not using
Yeah,
chlorhexidine.
even in AIMS also we are not doing it with cleaning with saline. We just use a triple swab technique, that is spirit, betadine and spirit. So we are not doing chlorhexidine in AIMS.
Ma'am,
Yes.
I'd just like to clarify one small point, ma'am. My senior Dr. Jyoti is here, ma'am, today to coordinate the session. I'm Pramita, ma'am, by the way. So Dr. Jyoti is right here. Okay, ma'am.
Okay. Okay. Hello.
Ma'am,
What is your take about cluster care? Do you practice cluster care in your unit?
Cohorting. Okay. Yeah. What is our practice? You asked, madam. What is? The question was not very clear.
Cluster care. Cluster care.
Yeah. So we have here what we practice is we have negative isolation rooms. So there is a definite isolation policy, especially when there is an outbreak, maybe some viral infections or bronchiolitis like episodes. Negative isolation rooms are there. So we have 3 beds. And so these babies will be taken care in the negative isolation room, and 1 dedicated staff will be there. So there is a definite isolation room policy. So we have to wear all PPE and mask, and the strict hand hygiene has to be followed. And she is not allowed to take care of any other babies.
No, I'm talking about clustering of care, like, doing all
Procedures.
the,
Yeah.
doing all the,
Okay.
yeah.
So
Like
being
to
a
prevent infection, one is coming and giving feed, the other one is coming and giving antibiotic, the other one is not allowing baby to sleep and doing different activities at different time, rather than doing the cluster of care to prevent infection as to increase the sleep time of the baby. So, do you have such any protocol in your unit?
Yeah, definitely, because our population is mainly, majority of our population is preterm babies only. And we do have babies as small as 24 weeks, 25 weeks, even up to 23 weeks. So this is very, very important as far as our unit is concerned. And dedication, nurse baby ratio is also optimal. So, unlike in a government hospital 2BC unit, we are able to provide maybe individualized care for such small babies. So, running between babies may not happen. In some cases, when the unit is busy, it may happen. But we are very much aware of the infection practices, and we usually do not encourage shifting of staff between babies. And development supportive care practices are also there. Whenever you are ordering any we are ordering something, we'll have to see that other investigation, everything should be clubbed together, and the baby sleeping time, which should be very well taken care of. And all such practices, ours is a level 3B unit, and all development support practices are being practiced.
On daily basis, on day-to-day rounds, we evaluate the babies for readiness for extubation to nasal continuous airway or non-invasive mode of intubation. And also on regular basis, we try to shift the baby as early as possible from invasive mode to non-invasive modes.
Yes.
Okay, and in routine, do you recommend head and bed elevation for 30 to 45 degree?
Yeah, that is routinely followed for all babies, even for term babies and all babies. That's all the practices. Head and up elevation, ET tube should be shifted to one side so that dribbling of condensate should not directly happen to the lungs. That has been practiced, and oral hygiene, even though that is not recommended for babies, we do give oral hygiene cleaning, and oral colostrum painting has been practiced. So whatever there and strict infection control practices, we have dedicated equipments and articles for each bassinet. So we will not be sharing the equipments, especially ambu bag and all. Once it is it is open, we will never use it. It is one time use only. And since these babies are very tiny, there is a high risk of infection. So after opening the ambu and using it, it will be going for ETO or plasma sterilization. So always this is very, very important, especially cross infection. To prevent cross infection, it is very important to have dedicated equipments for each baby. Even your measuring tapes or thermometers or stethoscope, all such items should be answered. There is a FAB bundle checklist, and so that also is followed. And it is pasted. We have all articles for each baby will be kept in a box, and it will be kept near the baby.
Ma'am, will you be able to tell us how do you perform the oral care for these babies?
Oral care, whenever regular, since in small babies, this disturbing or development supportive care is also very important. So we should not be very often cleaning the oral cavity. Maybe 6th hourly we practice oral colostrum painting, 0.1 ml of oral colostrum as early as possible whenever we are getting it to each cheeks. We'll be using a tuberculin syringe, and we'll apply 0.1 ml of colostrum to each cheeks. And then during that time, maybe the sisters using gloved hand, they'll rub it over the cheeks, and if some secretion, something is there, they'll clean that area. So carefully, we'll be looking in the oral cavity for any pooling of secretions. It will be there because we are not doing regular suctioning. So this will be seen and monitored maybe at 8th hourly or even less in very small babies like 24 week and all. Maybe we'll be doing it 8th hourly or 12 hourly. So this practice is there. Some secretions is it has to be cleaned, and every time before you are changing the tube or any that time you have to clean the oral secretions, because re-intubation or you doing your ET suctioning and all, you have to make sure that oral cavity is clean and no secretion is there going into the pharynx or oropharynx or into the lungs. So that practice is also there.
Meena ma'am and Pratima ma'am, are we also practicing? Are you also practicing the oral care in the units?
So we don't practice anything regarding oral care. Just if at all needed, so just apply ABM, but that also we hardly do in names. What about Pratima?
This is
Yeah,
also
yeah. We are following oral care in the form of, not allowing it to crusting to happen in the lips and the oral cavity. Sometimes if you are giving some orogastric feed or something, and there is some, whitish layer which is there in the oral cavity, or the lips are just crusting is there. So that we moist, or that we just put colostrum or EBM, as Meena ma'am said. So that is the only thing we are following. We are not giving any other particular disinfectant or any other medicine as such for oral care. So these are the normal things which we practice for oral care. So you are doing suctioning oral cavity before ET suctioning. Is that what you are practicing? And do you practice separate catheters for oral versus ET suctioning while suctioning? Is
Separate,
it so?
yeah, separate catheters are used, or it is not done only if secretions are there. Sorry.
No,
So-
please continue, I think.
Yeah, it is regular suctioning on a regular basis. It is not happening. Only if secretions are there and baby is desaturating, as shown in ventilator graphics, or some desaturations is there, we'll do that. And ET secretion, ET suctioning, and for oral suctioning, we'll do separate catheters. Always, never we use the same for both procedures. It is always
I think
separate.
ET suction is, ET suction is one procedure where utmost care has to be taken. And no routine use of saline and bicarbonate also, I think previously people used to instill it routinely. That should not be done. And even the suction bottles and the catheter, the connecting catheter has to be ensured that it is cleaned every day. So that is one thing. And how do you prevent the
But then we should
condensation? You
not,
have been telling, yes, Kidanjali.
yeah, I was just wanted to say that if only the secretions are thick and only that time we can use a little amount of normal saline, otherwise not in routine.
Yeah, not routinely कि सब में नहीं डालना है, only when there you feel
Secretions
that.
are thick.
That also case to case basis. I think
Yeah.
it should not be in the policy as such. You can just decide then and there. Yes.
Yeah.
So what are the points
for
to be
normal-
taken care of? Yes, sir. Yes,
Yeah,
yes.
I just
Kitan.
also wanted to know how frequently the ventilator circuit is changed in their unit. I mean, they have not mentioned specifically anything about it.
Last time we had a discussion on that, madam, so that as it is a continuation, so we didn't mention that. So the recommendation is it has to be changed only when the circuit is soiled, but here we are doing it weekly, in fortnight. There are clear guidelines are there, ARC guidelines are there, the circuit has to be changed only when the
Visible inside. It is visible
soiled.
inside or it is malfunctioning. Only then it is to be.
We are not changing any at a particular interval. We are changing only when it is soiled,
Yeah,
visibly soiled.
that's the recommendation actually.
So yeah, I was asking what are the measures you take to prevent condensation? You have told that there should be no condensation. So what measures can you take bedside? And not only for ventilated babies, I think to ensure because then the secretions can actually go back to the patient in the circuits from the circuit. So any two or three steps which you can think of?
Condensation is a big problem everywhere. Actually, because recently we have changed our humidifiers, and so that brought a major change. After this, humidifiers are we have changed to new Fisher-Paykel humidifiers, and it is very good. And we have hardly seen any condensate in that. Previously, it was a problem, and we would cover the temperature probe and we would keep it inside the warmer, so overheating has to be avoided. The temperature probe and humidifier should function properly to avoid condensate. So that has to be taken care of. When it is getting old, it will get malfunctioning, and then this can cause condensate. Whatever measures you take, like they say, to you cover the temperature probe or keep it outside so that it is not inside, so that the temperature difference may not happen frequently. So whatever measures we did, it was not helping. Since after we changed our circuits, now the condensate problem is much less. Zero.
So for the units who cannot still afford the newer ones, humidifiers, of course, the quality of humidifier is very important. But the bedside procedures which can be done, as you said, is keeping the ambient temperature within the normal range. Do not, put the circuit in a very cold or with the AC draught. So there the condensation can increase. Secondly, faulty temperature probes. If the temperature is not showing properly, then it needs to be replaced. So the newer humidifiers, of course, are chip based and they do not require those temperature and heating wire probes. And third, if possible, dual heated wires, heating circuits can also be used, which can actually reduce the condensation. One or two points which may be added to the insertion bundle. You very well covered the three steps. I mean, insertion bundle, maintenance bundle, and then even while removal, there should be a removal bundle also. While you are removing an ET, extubating a baby, or while you're removing a catheter, same amount of asepsis should be followed. there can be adverse events like the tip remains inside the baby if you're pulling too strongly. And if you're not properly following the asepsis while remover of the catheter, that also predisposes to sepsis. So that is why the third bundle which can be added is the removal of the catheter bundle. So what do you do when the ET is actually higher up? If you check the position of the ET, I mean the doctors must be doing, it's a teamwork. Or if the line is just below the line of insertion, so can you reinsert the line or the ET?
No.
Or do you need to push it back so that it is in
No.
position?
We will never do like that, ma'am. We will insert a new line that
Very good. So
reinsert.
never push any line or catheter inside whatever is indwelling line is there. You should always reinsert. You can pull it out, but never push it in. That is one step. And do you use your central line for giving antibiotics, medicines like caffeine, phenobarbital, or any other medications and blood transfusions? Do you use the central line for that?
Usually, we are not using central line for that purpose. For less than 24 weeks, if the line is difficult, then only we are using this central line for this antibiotic use. Then also, we will prefer a peripheral line for blood transfusion. We will prefer a fresh new line for blood transfusion. That is our hospital policy, ma'am.
Yeah, so the main thing to be taught is that don't open the hub again and again. As far as possible, keep the circuits closed, whether it is for prevention of VAP or prevention of your CLAPSI. The circuit which you have formed with the IV line, infusion pump, all the circuits should be closed and they should not be handled too frequently. The more you open the hub, the more the likely source of infection. So that is why you should have a separate line for other medications for which you need to actually remove the hub twice or thrice a day, perhaps. And of course, blood transfusions should not be given. First of all, the caliber of the catheter, PICC line especially, can be less to allow the transfusion to happen smoothly. Reactions can occur very fast if given in a central line. So that is the thing. And while inserting, always place a transparent adhesive so that early extravasation is detected and it can be removed. So one thing more which can be added in the VAP is auto-filling of the humidifier. So never open the chamber to fill the water in the humidifier chamber. Always use auto-filling by using a separate distilled water bottle. I think you must be doing that, but all of you should take care of that. Yeah, that was the points
And
we
the transparent dressing for the lines, it should be changed. How frequently it should be changed? The transparent.
Yeah, what is your practice? We are not changing if it's not soiled visibly. We are
If it is
not
not
changing.
soil, it's not changed.
When we see daily, we'll be looking at this attachments, whether it is soiled or loose or damp. If it is loose or if it is damp or if it is soil, we'll remove the dressing and replace it with the new dressing. One more point, what we are practicing here is it may not be good for infection. And since our babies are very small, skin is very thin. So we will not be removing adhesives immediately if we have a PICC line or if we have a umbilical line. After removing the line, we'll immediately will not be removing the adhesive. So if it is a Dynaplast or whatever it is, it will be there. After few days, it will come out by itself. So that is also being practiced to avoid skin injury.
So, to add over here, it's not actually Dynaplast is not being applied to these. It's the Tegaderm. You can remove Dynaplast if you want. But Tegaderm, there are good studies also in order to prevent insensible skin losses, especially the units which do not have incubator, even in the units which have got incubators. So it is used all over the skin in order to prevent insensible losses. So you just leave an area for the echo. Otherwise, you apply it on the back, you apply it on the front of the abdomen, whether line is there or not. You apply it on the limbs. And because it's skin breathes underneath these membranes. And Dynaplast and all you can remove, but Tegaderm should be kept over there. Because in small babies, oil application, another is in order to prevent all this insensible losses is oil application. But applying oil on an area which is raw or which has got denuded or is excoriated is not recommended. But rest of the areas, in order to prevent insensible, you actually create prevention of air current convection heat loss by creating another micro layer over the body.
Yes.
And one very useful thing that we have found here is that we never apply Thermoplast on the skin directly because it's very, very strong adhesive and it's actually used only for giving good pressure or good adhesion. So anything that comes in direct contact with the skin is usually only Tegaderm or the pectin-based ones, the Duoderm. So any pectin-based biodegradable ones, which are very soft on the skin and easily can be rolled off. The Dynaplast comes on top of that, ma'am. That's what ma'am was saying. So we don't pull off the Dynaplast at all.
One more thing I wanted to clarify is suctioning is not done on a regular basis. Suction is required only if the baby is requiring a suction. That is when the baby is desaturating or any respiratory distress is seen or a ventilator graphics is showing the evidence that babies have some secretions are there. It is not that it should not be done on a regular basis, and especially in small babies, especially in the early few days, because any disturbance to the baby can increase the risk of IVH.
And to prevent any condensation in the circuit, to add upon these, like as Pratima said, that maintain the ambient temperature and all. And since most of you must be having centralized air conditioned units, so there are open ducts. So the bed or at least the ventilator circuit, if it is just underneath that duct, then the temperature varies and condensation happens. So you should make the direction of your bed, at least ventilator circuits, in a manner that they are not in direct contact with the AC ducts. Otherwise, if that is not preventable, then you can use, there are wraps also coming, but best is that you don't put it underneath that duct, otherwise condensation is very high.
Okay, ma'am.
And there are water traps which are automatic traps. There are there in the ventilators. If they are not there, then you can get them separately installed for ventilator. The newer ventilators, all SLE 6000 and the latest model of I mean Fabian and all, they are having this trap, which I'm not talking of the circuit trap. It is, this trap is actually on the back side of the ventilator, where your compressed the medical air is coming. So this trap is over there. It has got filters and it has got a transparent some bottle sort of thing, and the medical air, when it is entering into the ventilator, it prevents condensation at that level. And lots of unit like in PGI, I know what they have done is they have got installed a complete from where the medical air unit is entering in their unit, the 16 bedded unit, on that main supply only they have got this installed. If that is not possible, you can get it in the ventilators, like we got it done separately in our older ventilators. So that prevents condensation, because this remains a issue everywhere and is the biggest cause of VAP. Because non-invasive ventilation VAP, actually there is no such definition by CDC or any guideline which describe VAP for non-invasive ventilation. And in neonatology, we are doing, if suppose if we look at the number of ventilation days in a baby, the more number of hours are for non-invasive ventilation. And when we define the VAP, so this data is missing, and we erroneously false negative rather data we are creating by saying we are not having VAP, because non-invasive ventilation is causing multiple times VAP, which doesn't fit into the definition, so it never comes in the records. And we have to be
I
very
also feel
careful for
so.
this condensation.
Yeah, I strongly feel that the CPAP and NIV are equally responsible for causing secondary infections. hospital acquired infections, especially with the humidifier related issues and condensation issues. Water is actually what to say, notorious for causing the growth of microorganisms. So any water which is there in the circuit or contaminated water in the humidifier, opening the humidifier chamber again and again. So these all are actually crucial steps for preventing VAP.
Fantastic session, we feel, ma'am. Sharing knowledge with all of you and also understanding what each unit is doing. We have to titrate our practices based on what is available, definitely. The problems will be different in different places. The available resources will also be different. We've all worked in different places and come wherever we are. So, yes, we are aware of constraints as well as advantages in each setup. Thank you,
So,
ma'am.
I have also, in the chat written, what do we mean by clustered activity? Because by clustering, we mean any possible activity which is to be done with the child is designed at one particular time. Most of the unit, like our unit, we follow 6-12, 6-12, 6 a.m., 12 p.m., 6 p.m. and 12 a.m. again. And including all injectables, everything, you don't open up the incubator windows other than these 4 slots. The incubator window other than for this is opened only if the child deteriorates, or you cannot define the time of the X-ray person coming and doing it. So that is the only slot when this is opened. For us smaller babies which are there in the unit, ELBW, especially we put a special chart of clustered activity or minimal handling chart. So I've already put it in the chat box. You can see that. And I think Pratima, you can
Yes, sir.
conclude the session so that, and Pratima and Gitanjali, you can conclude. So then we will close this.
Yes, thank you so much, ma'am, for inviting us today. And it's one of the topics which is close to our hearts, I think. All of us, 3 of us, 4 of us, Meena ma'am also. Because sepsis is prevented can avert a lot of deaths, and we all are the backbone, especially the nurses. I think I day in and day out, we take rounds and we see that the residents are sort of dynamic group of healthcare providers, and you are the ones who have to be behind us. When we did residency, when we did our training, Meena ma'am and other senior staff, we actually used to get scared. So please empower yourselves. Always don't hesitate to, interrupt any procedure which is not being done aseptically, whether it's a line or whether it's the care of the support. And even on our daily rounds and clinical care, our aim is to actually work as a team. So very well covered points and good discussion, I think. And Gitanjali and Meena ma'am can add on. Technically, I think we have covered all the points. And motivation wise and inspiration wise, we all should work as a team, and because it's very difficult to implement these bundle approaches now. Ek hafta, 1 week, it's fine. But then again, things start to drag behind when the new residents come or when someone changes in the team. So it's our duty, the team members' duty as a whole, to look into it. Gitanjali and Meena ma'am, please, you can also add on, and then Suksha ma'am also. Thank you so much.
Dr. Pratima, you have already winded up nicely. I just want to add one thing. We can have a concept of infection control nurse. Maybe in each shift we can put a name of one nurse for infection control so that she keep on checking and reminding everyone to follow the bundles in the unit on regular basis. So that can be done, I think. Now I request Meena ma'am to conclude. Meena ma'am has to say something.
Okay, I want to thank Gitanjali and Pratima for taking this session, as because I was thinking I will not be able to do it because I am on trip not, it is an educational visit to MP, so I am at MP, and yes, most of the things are covered, and but if I missed the care of then I just want to add hub care, like scrub the hub. So whenever there is thick line, long line, or UAC, UVC, and you want to disconnect it, you have to scrub it for 15 seconds and then let it dry, and then you disconnect it. So scrubbing the hub for 15 seconds is very, very important. And that's it. If you have already explained, then just add on, just skip it. That's it from my side now.
I think everything is covered now. We can leave the session, and I think scrub the hub was probably missed. So thank you, Meena, for covering it. It was there? Okay, it's
It was
okay.
there.
It's okay. I might have
Yeah, it
missed
was there.
listening in.
It was there.
Thank
15
you,
seconds
thank you.
they
Thank
told
you
the
all.
duration. Yes.
Thank
But thanks for reinforcing. That's the important part. And we did. Yeah. Thanks.
Thank you, ma'am.
Thank you.
So thank you so much, everyone. Thank you so much for extending us the opportunity to host this session. So with all your permission, we would like to conclude the session over here and looking forward to host you again. Thank you.